All right, so here we are, hip fractures or joint replacement done by open reduction internal fixation, which is that like really gnarly type of surgery where we use hardware in order to stabilize a broken extremity. This can also be done as a result of advanced osteoarthritis. So when we get degradation of the cartilage that should be between bones that helps with articulation, if that gets degraded so we have bone-on-bone contact and that crepitus grinding of the bones with articulation, then they will get a joint replacement of knees or hips in order to alleviate a lot of the pain and discomfort associated with those types of advanced chronic diseases or acute diseases. So here we can see, just they made this one glow kind of fancy. So you can see the hip replacement up here and bilateral knee replacements. Person's like the bionic man. So for our assessments, for knees, usually for knees, that's the result of degenerative joint disease, our osteoarthritis. And what's going to happen is you can see, this is a kind of gnarly animation where the cartilage is all worn down. So we have that bone-on-bone kind of crepitus articulation with movement. And what they'll do is they'll surgically remove all the cartilage space, replace that with hardware that will then have a smooth gliding surface so that patients can articulate that joint without the same level of discomfort that they had before. So a lot of patients' mobility will actually increase after they have these procedures and recover from the acute kind of surgical aspect of it. For hips, two reasons patients tend to have hip replacements. One is traumatic fractures, so especially complications of osteoporosis. Patients fall down, land on their hip, fracture their hip, or fall in a way that fractures the femoral head, which is kind of the neck of the femur that attaches into the pelvis. Common place for that to break. Here's what the kind of hardware all looks like. So this big spike goes down into the femur, and we've got a cup that goes into the pelvis where they're going to articulate inside of each other. Degenerative joint disease is the other reason. So same as over here, the cartilage inside that ball and socket joint gets worn down over time from degenerative joint disease or osteoarthritis and becomes very inflamed, very painful for patients to move. So they do replace the femoral head with hardware so that that patient can move without as much pain and more effectively. Symptoms, well, sort of. Nobody really has symptoms of joint replacement, right? It's usually like a trauma or advanced disease. Surgery is just kind of surgery. A big thing we're doing with assessment is post-operative management of joint replacement, right? So it's a lot of our normal things that we do for all post-op patients, with a few little tweaks in particular for orthopedic patients. So nursing diagnoses that patients are going to have around joint replacement: impaired mobility, especially in the preoperative and acute phases, right? So immediately post-operative. Preoperative because they have advanced joint disease, limiting mobility, or they have a traumatic fracture, limiting mobility. Post-operative because they just had a major surgery, and they're going to need time for that inflammatory and pain to subside before they regain normal mobility. Knowledge deficit is a big one, especially for our hip replacements. There are hip precautions that need to be in place to prevent dislocation of that new ball and socket joint in the hip, and we'll talk about those in just a second. And then some common ones that apply to most surgical patients, but especially orthopedic patients who have had bone or joint surgery. Risk for surgical site infection. Cut them open, you've created a portal of entry for bacteria, so most patients who have surgery are at risk for a surgical site infection. And risk for falls, a big one. The way that those patients have been moving in the past is very different after they've had surgery. We've either corrected a physiologic abnormality or we've caused a trauma to a joint, which is going to alter, at least temporarily, the way that they move. So looking out for falls is a big, big deal. So for our plan, we're going to plan for CMS assessments, right? We've talked about this with fractures, but again, CMS assessment's really, really big deal, especially right after surgery. As patients prove that their CMS is intact after surgery, so days after surgery, we can start kind of pumping the brakes a little and get a little less concerned. But in that immediate post-operative phase, we get super concerned about blood clots, compartment syndromes, those sorts of things. And then our neurologic assessments. So again, looking out for those fat emboli, pulmonary emboli, any of our kind of obstruction of blood flow problems. We're going to worry about those quite a bit, especially right after surgery, and then kind of pumping the brakes as patients get further and further from their surgical procedure. We're going to trust that they're going to stay normal a little bit longer. When we combine these two things, we refer to that as our neurocirculatory exam, which is one of our really common ones we do post-operatively, but especially for joint replacement patients. And then mobility. So really, really big deal, starts very, very early. At the last hospital I worked at, the standard of care applied to patients who had a joint surgery was that they were going to walk from their post-operative or their PACU gurney to their hospital bed if they were staying inpatient. So they were going to be walking as immediately after their surgery. For total hips, it was going to start at 6 a.m. the following day. So it's going to be sooner than patients are going to feel they're ready to start moving, and we need to prepare them for that. Other ways that we can increase mobility if we can't do ambulation because of weight-bearing status or any other orthopedic restrictions is we can use what's called a CPM machine, or a continuous passive motion machine. So this is a device that you put usually like a knee in. We still see this after ACL repair, so soft tissue repair. And what it does is it'll just slowly, I'm going to pretend my elbow is in one, even though I've never seen an elbow CPM. It'll just slowly move my elbow through range of motion without me having to use the musculature in order to move. So that's what a continuous passive motion machine will do. Promotes mobility, right? We're articulating that joint through its normal range of motion as quickly as possible, but we're not having some of the pain exacerbation caused by having to use musculature in order to achieve that mobility. So for implementation, name of the game here with joint replacement, assess, assess, assess. Assess that joint, make sure that it is healing appropriately, and that we're not having things dying on us unexpectedly. So complications that we can expect just because of surgery, infection, infections that for patients who've had a joint replacement can be very, very severe because we have foreign bodies that are inside somebody. And that hardware is very, very susceptible to bacterial growth and kind of harboring bacteria on those artificial surfaces. So if patients develop infection and it settles on their hardware for their hip replacement or knee replacement, that can lead to amputation of that joint if they're not able to sterilize the patient. So it can be a big, big deal for patients who've had joint replacement with hardware placed. And blood clots, always a risk for anybody who has surgery, but especially our orthopedic stuff. Things we want to really focus on, get them moving. The only reason we do blood clot prevention stuff like the compression devices, the SCDs, which is sequential compression devices on legs, or heparin injections, is because patients are not as mobile as they would be normally. The very, very, very best way to prevent blood clots and promote healing in our patients is to get them moving. The body wants to move. If we prevent it from doing that, bad things happen. And in the case of joint replacements, those bad things are blood clots and infections. So we always, always, always want to get our patients moving. And then for hips, our hip precautions. We mentioned these earlier with the knowledge deficit that patients are going to have. There are specific behaviors that they cannot participate in because they've had an artificial hip placed. Those are things like crossing their legs. So their legs can't cross across the midline of their body. So they can't cross the spine. If they do that, it puts tension on that ball and socket joint and can lead to dislocation. Use of adaptive equipment for shoes and socks, because they're also not able to bend past 90 degrees. So their leg can come up to 90 degrees But past that, and there's also a risk of dislocation. And then internal rotation of the leg. So internal rotation, meaning instead of the foot being up, it bends in towards the midline. So that kind of flopping of the foot inward. All of those can dislocate that new ball and socket joint. So we want to be very, very careful of that. Oftentimes hip patients, when they come out of surgery, are going to have what's called an abductor pillow in place, which is like a wedge-shaped pillow that goes between their legs to prevent crossing or rotation of that leg while they're resting in bed. So anytime that patient's in bed, they will have that abductor pillow in place. Here's kind of what that looks like. So we've got that wedge shape in there, which is our abductor pillow that will help prevent some of the dislocation injuries that can occur post-operatively for hip patients. But the things we want to really watch out for: severe pain associated with the surgery, the inability to move their leg or a lump in their buttock, which would indicate that they have dislocated the extremity, so that would be bad. Also limb shortening. If we notice that all of a sudden one limb is pulled back and retracted, also a sign of dislocation. So just because they've got a new hip, they're not out of the woods yet. We need to make sure that they know how to protect that hip from further injury. So that is a big, big deal with our post-op hip fracture patients. Here's kind of a good infographic of all the things that we're paying attention to for our hip trauma patients. And that's it for ORIFs and joint repair. Next, we're going to be getting into amputations.